Okay, good morning, everyone, and welcome to Medical Grand Rounds. This is, we're 2 months into the COVID-19 epidemic here, and we're becoming pros at this. Zoom Grand Rounds will be the norm for a while to come. As you can see, I have a lawn that's growing out of control behind me, so I have some work to do after this meeting. So I'll quickly go through the agenda for today and the rules of engagement. So first, the rules of engagement. The only people who can project video and audio are the panelists. The audience is muted, so you will not be able to speak or share your video. The way you will ask questions is by using the Q&A tab. Please don't use the chat, use the Q&A tab. The questions will come as texts. I will be monitoring them during the course of the talks. We will try to respond to some of them along the way, and then we'll try to get to the rest of the questions at the end of the hour. If we cannot get to all the questions, I will compile those questions and have them answered by email or broadcast some way after the grand rounds. If you think of something after, then please email my office, Lisa Phillipson. Don't email the individual speakers. They are inundated with emails and phone calls. So email Lisa and she will collate all the questions and try to get them answered in an orderly way. So the agenda for today, we're going to start with testing. And the slide that you see up there is Dr. Dawn Riedy will present testing. Following that, we'll have our epidemiology piece by Dr. Emma Lesho. Then Dr. Laguio will talk about treatment. Then we'll have a brief update on what's going on in the ICU. And hopefully we'll leave a few minutes for questions at the end. So with that, I'm going to ask Dr. Riedy to start.
Thank you. Good morning, everyone. This is a new experience for me, so please bear with me as we go through this. I've got a pretty packed agenda of information to share with all of you. We're going to go through a chronology of testing in our laboratory, followed by the current testing indications, protocols by service line, stat results, Care Connect orders, and then at the end, some brief comments about serologic testing. This is the chronology at Rochester Regional Health for COVID-19 testing. We were selected on March 10th to be one of 28 labs in the state to be granted permission to begin laboratory developed testing without pre-validation and basically validate as you go. And Roberto Vargas and his team and a number of us who worked literally day and night brought testing live on Saturday, March 14th. So it took 4 days from the time we were told to ready, set, go to when we actually started. And I can never thank Marianne Formica enough and Dr. Walsh and Dr. Falsey who partnered with us. The first 2,200 patients we test using manual PCR. The RNA was extracted from those samples by Marianne, no one else, Marianne. We had the ability at that point to test 88 patients a day with a turnaround time of less than 20 hours. And I will just jump to April 6th when we began testing on the Roche instrument in the Elm Grove lab and ceased all reference laboratory testing. We currently have a comprehensive testing plan, testing on 4 semi-automated platforms in 4, soon to be 5 locations with a capacity of, we're now close to 700 tests a day. We pulled out the turnaround time last night from order to results. It's now averaging 15 hours with 4 to 6 hours for stat testing in hospitals from receipt in the laboratory. This is a clinically driven testing plan. And we could not have done this by ourselves, and we could not have done this, or you could not have had benefit of this in a healthcare system where the laboratory is just simply a vendor of services. So I'd like to point out two really important toolkit documents. I'm giving you the link to this section of the toolkit, which will take you to the testing portion under the employee toolkit. And the two documents for everyone to keep an eye on are the COVID testing fact sheet. We updated it yesterday. It will be posted to the toolkit today. It gives a history, strategy, and overview. This is the document that we are using for media inquiries. And one thing in this document that I'd like to point out to everyone, and people hear me say this a lot, you really, really need to be careful with asymptomatic testing. If we test a symptomatic patient and we tell you they're positive, they're really positive. If we test an asymptomatic patient and tell you they're negative, there's a high probability they're negative. It's not assured, it's not 100%, and you as providers need to not step back on PPE, and patients need to not step back on continuing to mask, social distance, and good hand hygiene. And the second document has a much longer title. It was last updated on 5/1. It will be updated again this week, and I'm going to walk you through some sections of that document. That document starts with some general information, including the COVID-19 RRH Lab Director on-call schedule, which is available in IntelliWeb. Dr. Vargas and I share this responsibility. Pretty much I'm on from midnight on Wednesday till 8 in the morning on Sunday, and then we switch. But you don't have to remember anything, you just have to know to go to IntelliWeb. To emphasize the importance of having excellent nasopharyngeal samples in order to have an accurate test result, we have just completed a trial using nasal swabs with collection by an experienced provider. And when we compared the nasal swabs to the nasopharyngeal swabs, we saw about a 13% decrease in sensitivity. So we are not going to be offering nasal swabs. That is yet another reason why you must be very careful if your patient goes to a testing site, such as the FEMA testing site at the Hudson Avenue Walmart, because not only are those nasal swabs, but they're collected by the patient. So there's a very high false negative risk if you don't have a good sample to start with. We are planning to expand the location where swabbing can be performed, particularly for asymptomatic patients preparing for procedures. And I would encourage everyone to watch for updates over the course of the next week in the daily briefings and other announcements that will come out through System Incident Command. Testing indications in this document are divided between symptomatic and asymptomatic. I've had a number of questions from providers asking me what symptoms are suggestive of COVID illness. And that really needs to go back to each individual provider, needs to take responsibility if you're going to be ordering the test to understand what the very broad range now of signs and symptoms might be, including things like stroke. And then under the asymptomatic testing, again, a caution about what an asymptomatic negative means and what it doesn't mean. And this is not a best 2 out of 3. We had an unfortunate situation this week where a patient was swabbed in one of our tents in preparation for a procedure. The result came back negative. The patient did not believe it and contacted their local health department. The local health department re-swabbed them with a poor quality swab. The result came back negative the second time. This patient has a strongly positive result and is definitely positive. So if you have a question about a result, then I would encourage you to call whomever is on call, either Roberto or myself. We can double check the curve. We can make sure there are no clerical errors, but this is not a best 2 out of 3. We'll talk about stat testing, and then I'm going to show you an example. We put together testing protocols for SMS, obstetrics, long-term care, behavioral health, and occupational health. We will be updating those later this week to optimize testing for BHN residential facilities, and to expand, I know it's not really called long-term care, but to expand strategies for elder one and assisted living facilities. Under symptomatic, I'm going to refer you to the documents in the toolkit. They are divided between pandemic risk, personal risk, and patients at risk of exposing being exposed or being exposed by others. And the items in blue to point out are the recent addition, in addition to, there's a jackhammer upstairs and I can't control that, I'm sorry. But in addition to healthcare workers and first responders, any position within a nursing home, long-term care facility, or other congregate living facility becomes a pandemic-related risk. And that would include things like corrections, parole, and probation officers, and folks in working in residential care settings. If you need a longer list of those indications, they are in the New York State Department of Health guidance documents, which are available to everyone. The recent New York State guidance documents also split apart underlying health conditions and age. It used to say significant health conditions 65 and older. Now it says underlying significant health conditions of any age, and then a separate category is symptomatic individuals age 70 or older. And then under the third category, to point out that we are also including household members of all of the patients at risk listed above. So for example, my own husband, if he was symptomatic and went to a tent, would qualify for testing simply because he lives with me and I am a healthcare worker. So he doesn't need any other reason. If a household member of a pregnant patient who's symptomatic should be tested. So that household members, households of patients at risk is a very important category. We've actually been using that for some weeks. I just want to highlight that. Under asymptomatic indications, pre-op, pre-procedure, pre-treatment, obstetrics, behavioral health concerns, long-term care, congregate living and homeless, and infection prevention. I want to highlight just a few. I'm getting lots of questions about which procedures. I have asked for help from System Incident Command to provide an outline of categories. That's not for me to decide, nor me to answer all the individual questions. That's for all of you as a group to decide. The behavioral health includes not only admissions for psychiatry and chemical dependency, but also any other individuals who you feel may not be able to comply with masking and social distancing. So that could include patients with dementia or patients with mental health issues, but admitted to a medicine unit. It could also include severely developmentally disabled individuals or children, anyone who you feel may not be able to comply either in the hospital or in a residential care setting with the rules, if you will. The long-term care congregate living, we've also included homeless in that category. So we are testing asymptomatic individuals being discharged to long-term care facilities or any of these other types of facilities listed, as well as in between those facilities. So working very closely with Scott Schabel, who is absolutely my hero. Roberto and I work together with Scott every day. He is managing about 40 long-term care and assisted living and other congregate living facilities in our community very closely with us. We would test a patient at discharge from RGH to St. Anne's for rehab and then test them again before they go back to their assisted living facility. So we are prepared to manage this in a very robust fashion. We are also offering, we are not mandating, but we are offering testing to patients being discharged to live on the street, because that's actually a congregate living situation also for a population with limited access to robust healthcare services. When we talk about results notification For all of you as providers, you're getting these results the way you would normally get a result. For patient notification, this is being done through Bridget Weefling and Rebecca Alley's absolutely amazing 7-day-a-week nurse call team, only for symptomatic patients who were swabbed in the tense and urgent cares. All other results are the responsibility of the ordering provider, both for communication of results and for counseling of patients about what those results mean. Patients are getting their results in MyCare, and very shortly we will be adding advisory language in the MyCare result about the significance of both an asymptomatic negative and an asymptomatic positive result, as well as advisory language telling patients that if they get sicker or develop symptoms, they need to immediately seek a higher level of care, up to dialing 911 if they're really that ill. This is an example of a service line protocol in the Toolkit document. I picked OBGYN because this is an example of something that we thought we knew what we were doing last Thursday and finalized the document at about 6 p.m. And by 9 p.m., the national and state guidance had changed to include labor support persons, so we had to start all over again. So we have a process for managing asymptomatic persons, patients and labor support persons for scheduled C-sections and inductions, for urgent C-sections and inductions, and clinical evidence of obvious, imminent delivery, and then spontaneous labor and delivery once the patient has arrived in the hospital. So we are really trying to cover our bases in numerous ways. I'm sure this isn't perfect, but we're doing our best. Stat orders are driven by the order set, and I would encourage everyone to look at the order set. You order COVID, you pick symptomatic or asymptomatic. There are indications. The indications drive whether it's routine or stat. We discovered last night that you can override it, and we're going to fix that today. When you order other symptomatic, it is routine, period. It's not a stat order. If you have something that doesn't fit in one of these categories, you can use other and then tell us why you think it needs to be stat. If they're asymptomatic, again, the clinical indication drives whether the order becomes stat or routine. We are not calling you with those results. You're responsible for the results. We're asking you for a name and phone number only because, as occurred this morning, if we have to refer for secondary testing to Elm Grove Lab, it will extend the turnaround time by another 4 to 6 hours. If that happens, Roberto or I will call you so that you can then make a clinical decision about whether to proceed with testing, with your procedure, or wait for a result. Comments about serologic testing. Testing needs to await a clear purpose. There is no role for IgM testing for acute infections. Everyone should be using the PCR testing. Currently, all of the available semi-quantitative assays do not prove immunity. We theoretically have access to a lab-developed test through Mayo Clinic. It's a lab-developed test. It costs money. Because it's a lab-developed test, we are not reimbursed for it, and we are not currently offering it. We are developing in-house testing on 3 different platforms, and we will have one of these up and running before the end of the month. And before we begin any testing as a system, we need a plan for how the results are going to be used. We've already brainstormed a number of ideas for this, and I'd like to point out that I think the greatest risk of serologic testing is that it will change the behavior of the public. If you give someone a result of, yes, you have IgG antibody, and they stop doing all the other things that they should be doing, then we're going to have a huge problem. The ongoing challenges and plans, they're in the slide deck, and I'd like to stop by just thanking everyone who has supported us. I've never known so much about IT before in my life. Roberto has honored me by naming me an honorary microbiologist. I couldn't do any of this without Roberto's side by side. We're literally shoulder to shoulder. And then literally there are 500 service line colleagues everywhere from the transporters to every phlebotomist in the community. I'm going to need all of your help meeting the system-wide phlebotomy needs. of our patients. You will be hearing more about this today from Rob Mayo and me. We actually have a very serious and urgent problem to address in the home draw space, and we're all going to need to work together to solve this. So that's my last slide.
Thank you, Don. I'm going to ask you a couple of quick questions. We're a little over time, so we won't get to all of them. So one is from Jerry Gasiak. When can we start COVID testing on all the 50 to 70 patients admitted through the ED or direct admit to RGH?
So right now we have capacity to test 600 to 700 patients a day. We will need to be able to test somewhere between about 2,000 to 3,000 in order to do that. And I'd like to point out on this slide that if today we were running all of our 5 instruments at maximum capacity, which would be 2,900 tests a day, we would only have enough swabs for 5 days. So we're actually in the process. We're going to have to set up a manufacturing line somewhere, somehow, very quickly to make our own sample collection devices. So we theoretically, if we can convince Roche to give us enough test kits to test all admissions, the next, and actually the first hurdle, is we don't have the sample collection devices. I've got requests from OBGYN to release sample collection viral swabs for vaginal swabbing, and my answer is no. I've sequestered all of them. And even with we only have 15,000 swabs in the entire system this morning. That's it. We have a whole task force. So we're pulling out the stops. If anybody knows, anybody we can talk to, we're working at a system level on a task force. We don't have enough swabs. And I'm going to take 30 seconds to also let you know that we are working in partnership with an amazing individual, Dr. Jeremy Berg, who is working with Roberto to immediately investigate every new testing option we hear about. Jeremy is the immediate past editor-in-chief of Science. He is a former director at NIH. He is working his tail off for us, completely free, and he's also my brother-in-law. So we are literally, this is a family effort, and we are doing everything we can to expand testing as quickly as we can. We can't test all admissions until we have enough swabs.
Yep, got it.
That's the rate limiting factor.
Yeah, so are we testing SNF patients before they go home from SNFs? This might be a question for Emily.
Not yet. No, we are not.
Not yet.
So
Okay.
we are just now testing asymptomatic admissions and transfers. Scott, you're probably on the line. You and I need to have a long conversation because I learned yesterday that as of 2 days ago, there is a statewide initiative to test every single long-term care resident and employee being aggressively conducted by the state, and they are not coordinating it with any health systems. It was a shocking phone call, and this happened at about 5 o'clock yesterday afternoon. Scott and I have not even had a chance to discuss this yet.
All right, well, we're gonna move because we have a couple other things to cover and we're already into the hour. So Dr. Lesho,
Yep.
let's do the epidemiology here.
Okay, here we go. A ton of data to fly through, so I just want to begin by apologizing to somebody I'm going to forget to thank because there was a situation happening on 7800 that we wouldn't be able to get here and have the story and the successful outcomes without having everybody brought to bear and the incredible opportunity to work with a wonderful group of team members. So this is the result of unbelievable support from the laboratory, environmental services, the leadership, nursing, occupational health, infection prevention, and goes on and on and on. So this is an animation of what unfolded on 7800. So 22nd of April, the index case turns positive. 2 more patients on the same side of the hallway, followed by 3 more patients on the same side of the hallway. And there you go. So the red numbers indicate the order of the patients. The green indicates that the patient was already discharged by the time the test was positive. And you can see the situation there. So the date, for example, number 8 down in the corner was the 8th patient to turn positive, and she or he had spent time in that room from the 22nd to the 28th. So that's what that, and you see a majority are clustered here on this side of the hallway, right? And so the letters correlate to what healthcare workers had contact with that room, with the patients in those rooms. And you see up to 5 healthcare workers had contact with the index patient right here. What the asterisk for healthcare worker I shows is that healthcare worker went for a long period of time, almost we're done with the investigation before even developing any symptoms. So that'll come into play a little bit later. When all was said and done, there were 145 exposed employees on this ward from the exposure period of 420 to 427, and there were 48 potentially exposed patients. I'm sorry, 145 potentially exposed employees, 145 potentially exposed patients. So we began the outbreak investigation, and we initially noticed that a high number, not high, but an unexpected number of healthcare workers who were relatively asymptomatic tested positive, and the same was true for the patients. And so we had to ask ourselves the question, not having seen COVID before, what is going on? Is this just a reflection of a high prevalence of pre-symptomatic, quasi-symptomatic, or asymptomatic COVID in the background? Or is there a potential problem on this ward with a breakdown in infection control practices, or a super spreader, or something else? It should be mentioned that the index patient was a patient with behavioral issues and was on the ward for 3 weeks before she developed symptoms, and rapidly deteriorated and was transferred to the ICU. In order to calm the patient and reassure the patient, it was often required at night to put the patient in a jerry chair and keep her at the nursing station. So similarly, the patient was had very difficulty complying with requests to wear a mask and to stay in her room. She was often found wandering. So some of the first patients on the ward that we tested were patients that the rooms that she frequented, and those patients were positive. So that's where we are, and then we have several. So what is happening as we're currently undergoing this investigation? We're learning a few things. So with the support of a very supportive leadership, we were allowed to perform what is one of the gold standards in epidemiology, a case control study. So we selected a positive and negative control ward to see how the results differed from our case ward. The negative control ward was 2,800 because that's a ward where patients were not being sent who had COVID. It was relatively considered a COVID-free ward. The positive control wards were the COVID units, 4,800 in the MICU. And so we tested every other patient on those wards. We didn't have to test the patient on the COVID wards, obviously, but we tested the patients on 2,800 and a random sampling of volunteer staff from both wards. And we learned that there were no patients or positive staff on the negative control units, and there were no staff that were asymptomatic on the positive control units that tested positive. Intermittently, there was a few employees that developed symptoms and tested positive, as would be expected during the course of the outbreak, and at least 50% of those employees had close contacts with a family member who was also positive or worked at another hospital. In addition to that, with the support of, again, the leadership and the lab, incredible support, I don't think we'd be able to do this at other locations. With the support of environmental services, we're now having tested up to 200 environmental samples. And we test the samples randomly, the surfaces randomly. We test them at various points in their cleaning. And what we are seeing roughly right now, again, and data reports are coming in right now as we're doing this. So again, I apologize for not having this on slide format, and some of it's sort of proprietary and sensitive information that we don't, we're not ready to distribute yet. So about 10% of the surfaces that we're testing are positive. That's the random surfaces. That's in any state of cleaning. That's if you were just to walk through the wards and test here and test there. We had a lot of experience swabbing hospitals in other situations. So we kind of, it's not that we don't know what we're doing or we're just looking for stuff. We have a reason for doing this. One of the places we focused on, because one of the hypotheses was that there could be a breakdown, I don't even want to say a breakdown, but that in social distancing, we know that the staff have very limited break room, space. On the wards, the break rooms are small, and that's something you can't control. And staff need a place to go, to eat. And so the good news was, on our initial round of sampling all the break rooms on all the wards, we did not find any COVID. And we sampled the microwave buttons, the refrigerator handles. On one of the break rooms, on one of the floors, on the floor, it was pretty dirty. We did find COVID. And we tend to find COVID occasionally on the floors, and we don't know what that means. We're finding the RNA, I should say. We can't culture it, and that's one of the limitations. Now, next we want to know is how effective is our cleaning? So that's where we have the incredible support of the environmental services. So when a COVID patient is discharged, right before they terminally clean that room, we go in there and we sample. They then, right after, they then terminally clean the room. They zap it with the UV light, and right before, almost immediately, we go back in there and resample the surfaces. And that's what we're in the process of doing now. And we have some preliminary results on that. But what we're seeing, just for everybody's awareness, consistently throughout the hospital, you have to watch for shared equipment. So the glucometers, the handheld glucometers were positive for RNA, COVID RNA, on the COVID wards and on the case ward. Fortunately, we didn't see it on the wards that didn't have it. So watch out for handheld equipment. The people that have ever tried to get a laboratory sample from a patient on the wards, know that you have to drag the computer in to the bedside to scan the patient's wristband, and we found several wows that were positive. So they're areas of concern. Sinks are typically known to be a culprit in multi-drug resistant organism transmission, and we found a few positive sinks. And so that's, a detailed summary of our environmental sampling is yet to come. You might say, well, what is the role of environmental RNA or DNA? And because we can't culture COVID, because it's a bio level 3 pathogen, we're limited in that spec. So I can't fully answer your question. Well, what is the meaning of finding this? Is it active DNA or is it inert fragments? So can somebody raise the question?
I interrupt you for just 1 second. Can you look up and look at the mic when you talk?
Sorry. Yeah. And then is it a fragment? What is the meaning of the fragment? Or is it a full fragment? So normally what we would do is we would culture in tandem. With a molecular PCR, we would do a tandem culture. We can't do that here. The other thing you could do to control it, sorry I'm yelling, but it's the chainsaw in the back. The other thing we would do is we would correlate it with the number of healthcare associated infections. And so in the past, for example, you have E. coli DNA, you have environmental cultures that grow E. coli, and then you look at the number of healthcare associated infections, bloodstream or urinary tract infections with E. coli. And if there's high discordance among any of them, with the DNA or the RNA, you say, well, I guess the RNA doesn't really mean anything. Or if you're not culturing it, the RNA doesn't really mean anything. And so to try to answer that question, again, Dr. Walsh's group and Marianne Mike have been very generous and allowed us of this, which is very limited, of genomic RNA. It's the whole genome. So we made 1,000 and a 10,000 dilution of that, and we spiked certain surfaces that we're seeing how that compares, how it the rate of positivity or negativity of those spike surfaces following UV disinfection and surface cleaning. How does that compare to what we're finding? And that'll help. So then the final question is, well, what about PPE practices? Were PPE practices any different on the case ward versus any other ward? And preliminary results say not quite. They're pretty similar. About the mask compliance, what we look for is mask compliance. When we compare the outbreak ward, it's about 90%. It's about 90%, 75%, 82%, 100% on one, varies throughout the other control, the positive and negative control wards. We're looking at hand hygiene data. We're looking at face shields. And so what I couldn't show is a timeline of events that Jennifer Gutowski put together very nicely of all the interventions that we took. Some of the interventions are that the ward has been closed to admissions other than stroke. Every patient on the ward has been put on enhanced isolation precautions. We're in the process of contacting all the patients who have been discharged that may have been exposed. But it's hard, and that brings us to the question, what was the origin of this exposure? Our current hypothesis is that a pre-symptomatic healthcare worker perhaps transmitted it first to the index patient or one of the other patients that the index patient visited. And then the index patient just happened to be the first person to develop symptoms and rapidly decompensate. I should point out that the index patient was hospitalized in March before this and was tested negative for COVID at that time. And so the first question was that a false negative test? And none of my infectious disease colleagues or epidemiology colleagues believe that somebody would for 30 days have been happily, this patient did not display any signs for that 30-day period of fever, COVID-like symptoms or anything, even when you consider all these atypical symptoms, like the best we can do to help her. So that's one possibility. The other possibility that was brought to mind is a stroke patient. We're seeing that COVID is a coagulopathic condition. And, was there a stroke patient that had been admitted to that ward earlier and then that was discharged, but that may have also had asymptomatic COVID? We're looking at that. And interestingly, one of the first rooms that we sampled when we first started to do this, after one of those patients was discharged, had COVID DNA in it. And so more to follow on that. And that the possibility of that was again highlighted by a consult over the weekend where a 57 or 54-year-old patient whose only symptom was a severe MCA ACA stroke underwent thrombolysis, and during the whole event was tested for COVID and tested positive. But so more to follow. So those are our two hypotheses. Again, sorry, all the data is in disparate locations. Couldn't have time to get it all together, but if there's any time for questions at the end or your hypotheses, we welcome it.
Ask a couple of quick questions before we move to Mary Rose, because I'm seeing some questions in the box there. What is the specificity of the antibody test? Does it cross-react with other coronaviruses? Anyone know that?
I don't know.
This is Dawn. So are you talking about the IgM or the IgG?
IgG.
So the IgG, I don't think the issue is cross-reactivity. The issue is it doesn't tell you if the patient is immune or not. I
Right.
could certainly get more details from Roberto about that. And we've actually thought about doing antibody testing on this whole group of folks from the 7,800 outbreak as soon as we have the testing available in-house.
Gotcha. And then there's a question about sensitivity of the present kit in symptomatic patients. I think the answer is if the sample is good, the sensitivity is probably pretty high, correct?
If the sample is good in a symptomatic patient, the sensitivity of the current PCR assays is in the very high 90s, as is the specificity.
Yeah, sounds good. Okay, we're going to move on to Mary Rose. We'll let you display your screen.
Okay, great. So there's my slides. And how do I move this thing? Okay, great. So I'll try and be quick in the interest of time. And so I'll just kind of bring people up to speed, because I think the last time we talked about treatment for COVID at Grand Rounds was April 16th, which doesn't sound too long ago, but it has been a very long 3 weeks. And a lot of information has come out since then with a lot of new data. And some have used the metaphor that consuming all this data is like drinking from a fire hydrant. I guess it could be like that on a good day. Others have likened it to drinking from Niagara Falls. So with so much information that's coming out now, and trying to stay positive and say it's a great thing, there's an opportunity to learn, glean from the experience, and keep this guy's perspective and roll with the waves. So as a bit of background, and I'm just going to talk about 3 main treatments out. Updates on hydroxychloroquine, use of convalescent plasma, and then the third will be remdesivir. And I believe the last time we left off with hydroxychloroquine is that there was data leaning in its favor, but there was a lot of scrutiny about the data based on flawed methodologies or non-comparator groups and small sample sizes. So since last Grand Rounds, we actually have had similarly a preprint publication, but at least it was in the US, a larger size. It was retrospective study of hospitalized COVID patients in the VA Health Medical Center system. And they specifically looked at individuals who received either hydroxychloroquine alone, or they received hydroxychloroquine and azithromycin, or those who had received neither. And the primary outcomes they looked at were comparisons in the incidence of death and frequency of needing mechanical ventilation. They tried as best they could to adjust for the non-randomization by using propensity score adjustments. But ultimately what they found was that in comparison to not receiving either drug, in those receiving hydroxychloroquine, there did appear to be a higher risk of death. And also there were no significant differences in the risk for intubation. So aside from the traditional limitations of a retrospective study, on reading this, it makes one wonder, well, maybe there was a high probability for selection bias. Perhaps clinicians were electing to use hydroxychloroquine in people who were sicker and already were likely to have a higher incidence of dying, while conversely opting to observe those who are less ill. So this is all still unclear. But we do know that there are potential risks. And something that was published out of Brazil, which got also a lot of face time, was published in JAMA Network Open Access. Now this one was designed to be a randomized double-blind trial comparing high-dose versus low-dose chloroquine for COVID patients hospitalized and with severe illness. They estimated that they wanted to strive for a total sample of 440 patients. However, during the prospective safety monitoring, they noted that there were serious safety signals emerging, and it caused them to stop the study early at 81 patients. Most notably, they found that there were more deaths in individuals who were receiving the high-dose chloroquine. And in that group, there was a high incidence of QT prolongation compared to the lower dose. It was on the order of 19% versus 11%. So on stopping the study early, they note that, high dose and these side effects are certainly something to be cognizant of, and potentially specifically in the critically ill. So what does this leave us with the fate of hydroxychloroquine? Well, many societies, including mine, the IDSA, advised to use this with caution and ideally within the context of a clinical trial. There are many questions that we probably need answered regarding its role, particularly in the role of mild disease or in prevention of COVID upon exposure. And I'm looking at clinicaltrials.gov just last night. There are many studies nationally and internationally that are striving to answer these. None of them appear to be currently active out of Rochester, and we're not participating in any of these as a system, but the next 2 agents I'm going to discuss are 2 agents that we are participating in clinical trials for. So moving on, I'm going to talk about convalescent plasma. And this essentially is the infusion of plasma from a recovered COVID-19 patient with the goal of their antibodies to go in and help treat an infected and still ill COVID-19 patient. A general principle of passive antibody therapy is that time is of the essence. It's probably much more effective when used as prophylaxis than for treatment of disease. But when it's used for treatment, the antibody is probably most effective when administered early in the disease, like shortly after the onset of symptoms. This is felt to work via two main mechanisms. Either directly, the antibody binds to the given pathogen, and in this case, it would be the SARS-CoV-2 virus, and neutralizes its infectivity. Or indirectly, these antibodies could trigger antibody-mediated immune pathways such as complement activation and antibody-dependent cytotoxicity. Historically, convalescent plasma has been used in prior other viral diseases. It was used in the 1918 pandemic of influenza virus. More recently, in 2013, it was used in West Africa during the Ebola outbreak. And it was observed that individuals who received it compared to those who did not survived longer, significantly longer. And also in the SARS outbreak in Hong Kong, 80 patients had been treated with convalescent plasma. And it was noted that if they received treatment before the 14th day of illness, they had better outcomes than those who were treated later. So currently, regarding COVID-19 now, the convalescent plasma option would go something like this. A recovered patient, a COVID-19 survivor, would potentially be eligible to donate plasma if they met the current American Red Cross criteria, which are either proof of prior COVID infection with a positive PCR test, followed by a period of recovery at least 2 weeks, ideally longer, and then subsequent PCR testing that is negative, so they know that it is safe to go to the Red Cross and not potentially expose American Red Cross staff members to getting infected. Or in those who've no prior PCR but had a suspected COVID infection, and this I think is under the understanding that testing constraints were limited nationally, those individuals could provide serologic evidence of a detectable antibody in their serum and then be eligible to donate. So if someone meets either of those criteria and they meet the other criteria for eligibility of blood donation, such as negative HIV and other bloodborne pathogens, then they could potentially donate their blood and it could be part of the national pool of convalescent plasma. So to date, there have been 2 studies published with the experience of using convalescent plasma in COVID-19. And I'll go over just these 2 briefly. They're short. So the first publication was just recently, officially last week, in Proceedings of National Academy of Scientists. And this was a 10 patient case series from China in whom these individuals received convalescent plasma from recovered donors and that had detectable antibody. All 10 of these individuals had demonstrated severe COVID disease, either by requiring supplemental oxygen. 3 of them were on mechanical ventilation, another 3 were on high flow nasal cannula, and they also had evidence of bilateral ground glass opacities of the lower lungs. After infusion, it was noted that there were no serious side effects, and all had improvement in their symptoms, with 2 coming off the vent and 1 improving coming off of high flow nasal cannula within days of the infusion. The other study that came out more remotely in March was also from China. It was 5 critically ill individuals who were infused the convalescent plasma. And what was nice about this study is that they actually also measured other clinical parameters. So these are illustrated on the graphs on the right-hand side. And each line represents a unique patient. So with the x-axis being the trend over time, you can see what happened with each patient for each parameter. So starting at the top left is the cycle threshold, or CT. And the cycle threshold is a surrogate of the viral load. It is the amount of times the PCR has to cycle to get a detectable virus. So a low CT means a lot of virus, and a high CT means very little virus. And as you can see, following transfusion, the cycle thresholds of all patients, as detected by serial nasal PCR, gradually increased over time, suggesting there was a decline in the viral load after transfusion. They also looked at the SOFA score, which, as you may know, looks at multiple organ systems to get an assessment of how severe their illnesses were. And similarly, they noticed that post-transfusion, the SOFA scores declined, and the bottom 2 are the last parameters of oxygenation and body temperature, all showing trends in improvement. So from this, the authors concluded that these 5 critically ill individuals all improved following infusion. Notably, 4 of those 5 had been on mechanical ventilation and ECMO at the time, But by day 9 post-infusion, all 4 were off the vent and no longer requiring respiratory support. So as appealing as it is, it's tough to say without a comparator group how much of an effect the plasma contributed to these patient improvements. But I think it is a glean of what is potentially an option. So currently at RGH, we're participating in an expanded access protocol through the Mayo Clinic in collaboration with the American Red Cross. Eligible donors are encouraged to go to the Red Cross website, which is at the top, to sign up for an appointment to donate their blood. After the donation, the Red Cross is also doing serology for proof of prior infection, and then these donations will contribute to the national convalescent donor pool. For recipients, the currently eligible recipients per the Mayo Clinic protocol are those who are hypoxic, not necessarily intubated, but could be considered as having severe and or progressive COVID disease. And after informed consent is obtained, the clinical research group and us, we order the compatible group through the American Red Cross. Now, currently, the national supply is inadequate to meet the growing demand. So there has been a waiting period to gain product, and it's been long. It has been many emotions, but between 1 to 2 weeks. And by the time a product arrives, sometimes the recipient was already improved, or sometimes the recipient unfortunately passed. But moving forward, the hope is that as the national supply increases, as there are more donors giving in, they're eligible, the wait time for a product will decrease. And I'll just mention here that this is still investigational, right? The primary objective of the Mayo Protocol is to provide access to convalescent sera, to grow a national pool. The second objective is to learn if it is safe. And there are still many things that we need to learn about this agent. Just to name a few, we know that there are certain risks, some proven, like infection-related risks that we've tried to mitigate as much as possible, as well as infusion-related events such as trolley and TACO, the best acronym in medicine. But there are also hypothetical risks, such as antibody-dependent enhancement. So this is the idea that, is there a possibility of giving a patient antibody passively could inadvertently stimulate something that we don't want, like an immune reconstitution response that results in a worsening of symptoms? This is all theoretical, but it does give some centers pause in moving forward on this. Currently, as the Mayo Clinic collects information, they've had over 6,000 infusions in their multi-center trial per their website. This has not been observed, and there haven't been any safety concerns to say that the process should halt. But it's still a question that needs answering for COVID.
Mary Rose, can I just add that the serologic test that we're able to offer both through the Mayo Clinic now and what we're bringing in-house is a semi-quantitative test and could not be used to qualify a donor. I think that's important for people to understand.
Thank you.
They have to go through the Red Cross. So I apologize for interrupting, but just to clarify that.
No, that's an excellent point. And absolutely, since you bring it up, there's a lot of things that we don't know still, particularly donor issues. What is the optimal time of donation? What is the timing period where you're actually going to see enough antibody produced post-infection? Does the level of antibody production correlate with how severe the illness was? What is the right antibody level to harvest? Are these antibodies even functional or neutralizing to the virus? Additional questions regarding the recipients, what's the optimal dose? Currently, the protocol says 1 infusion, 200 ml, but is that adequate? Should there be more? If so, how often? What is the frequency? And when in the patient's illness is the best time? Is it probably better to give it early, but in conditions when someone may recover on their own, should you still give it? Could it be given too early? Are some individuals so severely sick with extensive end organ damage, is giving plasma to them too late? There are still many unknowns that we need to strive to gain. So last 2 slides, I'm gonna just talk about remdesivir. And I think this one has gained a lot of national, international attention. So I'm just gonna flash this timeline here. It had remained quiescent and quiet since 2013 to 2016 when it was used for the Ebola epidemic, and then also seeing whether it could be useful in vitro against SARS and MERS. And then when coronavirus started, Gilead, the drug company, started to look and investigate what was its activity against SARS-CoV-2, and it looked promising. And the first RCT was launched in China in January. This is the results of which just came out last week. It was published in The Lancet. And interestingly, they noted that they strive to enroll 450 patients to achieve an 80% power. But they could not achieve that many because they had already controlled the pandemic. So they actually were only able to enroll 236. And they note that their statistical power was reduced to 58%. In looking at their primary outcome, the time to clinical improvement in the intention to treat population, they did not see that remdesivir had a significant difference from the control group. Of note, the median number of days for time to improvement was 21 days for remdesivir compared to 23 days for placebo. They use the 6-point scale I have there on the left as their level of improvement. Essentially, if you're higher up on the rungs, you go 2 steps down, that's improvement. So they also noted that although it wasn't statistically significant, individuals who did get remdesivir within 10 days of symptoms did seem to get a little bit better faster, 18 days rather than 23 days if they got it later or got placebo. Also, mortality was completely similar. This is, I'm just going to flash here, the PCR viral loads were similar of the upper respiratory tract specimens versus the lower respiratory tract specimens, regardless of arm. And that information came out on the 29th. You barely had any time to digest it. Within a day, it was all over the news, preliminary information of what's coming out from another study. And this one was a lot more positive, so take it as you will. The preliminary study was, the preliminary data was from the 1,000 patients who were enrolled in the multi-center trial looking at severe COVID pneumonia. So there were centers in the United States involved, centers in Europe. Additionally, the U of R was involved. They looked at severe COVID, people who got remdesivir versus people who got placebo. And the preliminary data showed that duration of illness was significantly shorter in the remdesivir group. And there was a lean toward lower mortality in patients who received remdesivir. So to quote the FDA, based on this scientific evidence and the emergency use authorization criteria, it was determined that remdesivir may be effective, and since there is no adequate or approved or available alternative treatment, they moved forward to get an emergency use authorization. So this is all last Friday, like 5 o'clock. And so what does this mean for us? So I should say that there is expanded access via the drug company that has been ongoing since March that allows sites to have patients receive remdesivir for compassionate use in finite amounts. And Rochester General was able to be selected as a site for expanded access. So fortunately, we have been able to use the drug on site. It has a very stringent protocol in which an individual has to be mechanically vented and not have other acute or chronic severe organ damage. So it's a relatively finite group. Under the emergency use authorization, the language from Gilead is that it could be used for individuals, not necessarily mechanically vented, but who just have severe disease. Therefore, they may be hypoxic, or they may look like they have progressive disease. So it's slightly more free to use compared to the expanded access. The big thing this week has been, how is Gilead ramping up production? How is it planning to distribute a limited supply of product? And how is it going to do it equitably across the country and the globe? There have been calls from big societies that want transparency in the decision process, and they want there to be evidence that the distribution will be reflective of the burden of disease based on each of the regions. There are many calls for this, but as so far yet, there is no public information on who is getting the drug, where is it going, how can you be eligible, etc. So us at RGH, we have been trying to communicate with Gilead. Does participation in expanded access qualify us in any form. So more to come, and probably as voluminously as it has emerged so far to date. And with that, I will conclude. Thank you.
Great, thank you. Thank you for zooming through all these presentations. I think we're a little bit over time, so we're maybe going to skip the ICU numbers if that's okay. There are a couple of questions about testing that I think we ought to try to answer live if we can. Is that okay, Damanpal?
Yep.
Yeah, sure.
Yeah.
Okay.
So one is, yes, we do not have the bandwidth to test all patients being admitted. Should we be testing a subgroup, such as patients on dialysis or patients who come in from long-term facilities?
No, we should be following the indications that are outlined in the document.
Yeah.
We believe we need to ramp up all of the pre-admission testing, and we need to see what capacity we have once we've done that, and then we will expand as needed. But right now we need everyone to stick with the testing indications that are published in the toolkit, and there's a multidisciplinary group re-examining that every week.
Okay, so as we have increased capacity, we will.
Yes, and you need to be looking in the daily briefings for those updates.
Yeah.
You will get links to the updated documents as they come out. We are completely committed to offering the same service in all 4 counties that we serve. So we're not going to do one-offs of one dialysis center, but not another, and one long-term care. We are providing the same quality of care to every patient we take care of. So people need to stick with the rules, if you will. If there is an indication for testing that falls outside the bounds of what's outlined in the inpatient order, then you need to use the other indication and tell us why you feel that testing needs to be done. And we will always test first and ask questions later, but we're trying to be respectful of our capacity.
Sure. And the other question that's sort of a recurrent theme is there any group of healthcare workers that ought to be tested?
Not unless they're symptomatic or there's a known exposure. And that's very important as well, because, for example, if today we just went into the ED and we tested everyone, if they're asymptomatic, in the literature, there's very little in the literature, but what's in the literature says there's an up to 30% false negative rate. You could be brewing an early infection, but you would test negative. And the actual risk there is that it will change your behavior. You will be less careful about masking and social distancing, and in fact, then could become a spreader. So we are not testing asymptomatic team members unless there is an exposure event. And I just want to give kudos to Emil and the whole team we work with, Melissa. We've got a plan, and we know how to manage. We've managed 3 exposure events now. Each one of them, well, the first one was about 45 people. The second was about 20. And we've tested probably over 250 samples in this last one. We are able to get these results turned around very quickly and take really excellent care of all of our team members. So we're prepared to jump in, but no just carte blanche asymptomatic testing at this point in time.
Sounds good. Damanpal, any quick comment about the ICU before we?
Means I can show you one slide and maybe we can send it out. It's really don't have much time. Means ICU numbers are getting better. We have less patients now. This is the total since beginning. We had 49 total admissions, 33 on ventilator, 14 didn't need ventilator, 27 are extubated. Basically 6 patients are still on trach or ventilator. We had 2 patients who went on ECMO, and they are actually doing pretty good. I'm probably going to decannulate both of those patients on next week, probably Monday. Thing I would like for you to just quickly go over, if we have a few more minutes on anticoagulation. Throughout this 2 or 3 months, I think we missed early on some clotting issues, but later you can see since about 2 weeks out, we started noticing more clots and more data started coming, and we started to discuss this. We have about 16%. My guess is we probably missed, and we have 22%. So if you want to just talk about this slide a minute, I think that's important for the...
Yeah, I think it's pretty clear that this is a hypercoagulable state. So having this infection, COVID, makes people prone to both arterial and venous clot. So we have this is a data-free zone, unfortunately, but we have come to agreement with some major centers, and Peter Cuitas with his connection. You can keep displaying that slide.
Yes.
To use this algorithm, which is if you're admitted to the floor with COVID infection, but have a D-dimer level of less than 1,500, you should receive standard weight-based prophylaxis. If you're sick enough to be in the ICU, or if you're on the floor with a D-dimer level that's greater than 1,500, you should get intermediate dose, so higher than prophylactic dose, but not full therapeutic dose anticoagulation. Obviously, if you have venous thromboembolism, which you should be looking for and screening for, then full dose anticoagulation to treat. So we've been trying to follow this algorithm. I've gotten a couple of questions about whether patients who are at home with infection should be anticoagulated. And I think the answer is if they have other risk factors, obesity, smoking, if they're immobilized in any way, then they would be considered at high risk as well. And you might consider prophylaxis such as low-dose Eliquis orally in that subset. So I think with that, we're going to call this done because we're already 10 minutes over. And if there are questions that we couldn't answer, please email Lisa. There will be a video of this presentation that we will put on YouTube, hopefully by the end of the day. So thank you all very much for participating, and we can zoom on with our days. Thank you.
Thank you.